So thank you. It's a pleasure to be here. My hometown, born and raised over in the northeast part of town by Lloyd Center and Grant High School, Irvington District. Happy to talk to you about Scrambler therapy. I've been involved with it for a while. There's a couple of slides here for ACME credit designation and credit strategy statements, and this one too, a disclosure thing. And my potential disclosures are that Comparative Technologies did provide a couple of Scrambler machines and materials for us to do experiments at Mayo in looking at Scrambler for the last 6 years or something like that. Recently they provided a small amount of grant funding by paper. I haven't actually received it yet. Another potential conflict of interest, so this allows me to come home to talk, so you could consider that a conflict of interest. So presentation outline here, I'll start off with conclusions. It's kind of late and people might want to be resting here at this time of night after a good dinner here. First thing is that there's no proof that Scrambler therapy provides remarkable benefit. And I say this wearing my scientific hat. There have not been big randomized placebo-controlled clinical trials. Is that going all right now? Having said that, I'm virtually convinced that it actually does provide remarkable benefit for a large number of patients. And I say that wearing my clinical hats and my scientific hats. And I'll try and go through that for you in a bit to show you the data that are out there and about. So what is Scrambler therapy? That's the Scrambler machine. You see it here. Electrodes put on. It's cutaneous electrostimulation, similar to spinal cord stimulation, some people have thought, but it's not going through the spinal cord. You give the stimulation here that goes through the spinal cord before it gets to the brain. It is thought to provide in areas of chronic pain, where there's a feedback thing that there's pain here, when there's at times there is no acute sort of pain there. The message kept saying, and this is thought to send through the same nerves that are in the area of the chronic pain, no pain, normal self sort of message, and retrain the brain in there. It's USDA sanctioned since February 2009, and I'll go through the mechanism a bit more in a bit. So Scrambler therapy history. This is kind of a fuzzy picture, but it probably fits best, and it's actually even more fuzzy here. It's the best one I got on the internet. I had a picture of mine on the phone when I was over in Rome, but I couldn't find it. This is Giuseppe Marinero. He is the person who is responsible for developing this machine. He lives in Rome. He's not a physician. He is a scientist. Biophysical approaches to disease is what he's known for. He started off looking at ways of trying to take care of the problem of cirrhosis with biophysical things and electrical energy to try and get rid of some of the scarring in the liver, so therefore the liver would work a bit better. He then went from there into pain, and that's basically how Scrambler therapy arose. Now let me go over a number of clinical therapy reports and trials that are out and about. I'll start off with our Mayo experience. We've been treating patients for about 4 or 5 years now. A little bit of the history. How did I get involved in this sort of thing? I first heard about it from Tom Smith, who's a medical oncologist who was at Virginia Commonwealth University at that time. He now is at Johns Hopkins, head of palliative care there, and a medical oncologist. And he first mentioned it to me because he had heard about this. It was developed for chronic pain, not chemotherapy neuropathy. I'm a medical oncologist, by the way, and what am I doing with other sorts of pains that I'm going to talk about? And we'll get a bit to there, but chemotherapy neuropathy. And so he had done a pilot trial that I'll show you in a bit about this pilot trial. And he told me about it, and he told the company, Comparative Technologies, that was marketing the machine at that time, that I do a number of symptom control trials, do a number of chemotherapy neuropathy sort of things, so they might want to talk to me. They did talk to me, offered me a machine, and I said, golly, I don't know, I'm pretty busy with a bunch of things, and this sounds a bit crazy and that sort of thing. But I know Tom Smith well, he's a good oncologist, and I've known him for 15, 20 years. So I actually went out to Boston with a colleague of mine. We went on our own dime, a neuro-oncology colleague of mine. We went out and we heard Giuseppe speak and a couple of other few people speak. We actually talked to him one-on-one about it. My colleague kept on saying, well, how does this work? How does this work? How does it work? And I kind of said, Well, that's kind of interesting and fun, but I'm more interested in does it work, does it work, does it work? Those are two separate questions, both important. I'd like to know the answers to both of them. But anyway, I finally decided, all right, we'll take the machine and try it out, and went through Mayo processes and how we could accept a machine and all that stuff. And then we had somebody come out and did some training, and we were impressed by what we saw. We've treated over 200 patients so far. We've never charged a patient for it at this point in time. I think it belongs in clinical practice, and I'm working on getting that set up at Mayo. But right now, it's been on research sort of process. I did along the way go and visit Rome after a couple of years of doing it. I said, we need to learn more about it. So I brought the team there, and that was very helpful in saying, oh, we need to think about this and that and put things down in writing. We visited Providence, Rhode Island, where there's a big practice out there also. So the clinical trial we have, Scrambler therapy for the treatment of neuropathy and pain, an open access trial. This is not a placebo-controlled trial. It was developed to get experience to figure out what we could need to do to get a placebo-controlled trial going. It required that patients had pain or CIPN symptoms, and the CIPN symptoms were either tingling or pain, not just numbness, but of greater than 1 month duration, with tingling or pain greater than 4 out of 10 during the prior week. The treatment is that we treated them with Scrambler therapy to the affected areas for up to 10 30-minute sessions. Some patients, if they got pain, got better earlier, they could stop. If that pain all went away, some patients didn't go through the whole 10 treatments, and we'll go over that in a bit. So initially, what we did is we took our initial patient cohort, 37 patients who had chemotherapy-induced peripheral neuropathy. So most of you know that a lot of the chemotherapy drugs we can cause a lot of neuropathy. Oxaliplatin, paclitaxel is probably 80% of the problem because they cause a lot of neuropathy and they're used quite frequently. And then there are a variety of other drugs, cisplatin and carboplatin, not quite as much, bortezomib, and a few other drugs that cause this. So we took our first 37 patients who were enrolled in the study, and some of these are early patients there, and I'll show you in a bit that we improved over time. I think I'll be able to convince you of that. 25 had the most of the problem in their lower extremities. These are people who are all done with their chemotherapy, and 12 had the problem primarily in the upper extremities. During treatment with oxaliplatin, it's more of a problem in the upper extremities. Paclitaxel, it's always more of a problem in the lower extremities. But after you finish the treatment and you're following along, the lower extremities are the ones that are more problematic than the upper extremities. So these are data. This is a pain score of 0 to 10, and this looks at pain, not numbness or tingling. And this is what it is before the first treatment and then after the first treatment on the first day. So you give it, ask them what their pain is in the area, and then you treat the area, and then ask what it is afterwards, that thing. And then with the different 10 days, you can see that it decreased here over time. Now, we started with 37 patients, and there was a dropout of patients, 20 patients, and I'll go through that here in a little bit more detail. So it's not ideal for that process, but let me keep on going with this part. So we looked at the average CIPN scores on the CIPN 20 instrument, where we asked for pain, tingling, and numbness. And the pain scores at start were about 6 for all three of these things. They ended up to be about 3 to 4, with a 53%, 44%, and 37% reduction from baseline in these patients, with p-values that look interesting there that suggest that there's something going on. And if you look at the worst chemotherapy-induced peripheral neuropathy scores over the past 24 hours, they start at 6 to 7, and you end up with 3 to 4, and again, 40 to 50% reduction in both pain, tingling, and numbness. For some of these patients, when they get it, they actually get good sensation back, and they can feel things better than they could before. So the same sort of data illustrated here in plots, again with start day 1 on through day 10, drop out of some patients there with numbness, tingling, and pain, and they all get better during that time. This next slide actually shows you what I just showed you there, but we asked patients when they were done with their therapy, on a weekly basis, how much problem are you having with numbness, tingling, and pain? And we initially, when we started off, we actually did not ask that question during those 3 questions during the follow-up period. And so there's a fairly big drop-off of patients here. And the reason, and what we did ask though, from day 1, is we asked a separate question, which turned out to be somewhat confusing, and asked them, How bad is your numbness, tingling, or pain? Take the worst of them, and how bad is it on a scale to 10 scale? And that was somewhat difficult. Well, my pain was this, my pain was this, but my numbness was this, my tingling was, and so it caused some confusion, and that's why we decided to go to the individual questions later on. But what we saw with it is that it didn't seem like these patients did as well when they asked this particular question. And it might have been a bit more confusing. It should be a little bit higher, but it didn't stay down here. And we thought maybe it's some of the confusion. But the other thing we proposed is that maybe, because that included all of the patients, and we had a feeling that we got better as we went along, and so that might be because of that. So this shows you the exact same curve, looking at the numbness, tingling, or pain that I showed you in the previous slide. But we looked at in the patients that were early on, before we started asking those separate questions. And then the later cohort is in the yellow after we started asking those separate questions. And I think you can see that we did better with time when we asked in the last half of the study than we did in the first half of the study. And also, the number of patients in the first half of the study, where we didn't do so well, we started off with 23 patients. We only had 7 patients who were there on the 10th day. And part of that is because we weren't as good at it, we weren't getting as much results, and kind of the patient might have been a bit discouraged by it. And also, we actually kind of said, well, it's not working after 3 or 4 days, maybe it isn't worth you coming back. This is frustrating not only for you, but for us too. There's a little bit higher patients in follow-up because the follow-up could have been when you got done at day 5, we still did the follow-up thing, so that's why the number jumps from 7 to 12 here. But in this next group of patients, we start off with 14, and through 7 days we had 14, and we had 13 through 10 days. So we were more persistent, and/or we were better during that thing, and the drop-off here is not near so much, 12 out of the 14 that we started, as opposed to decreasing by 2/3 of the patient here. So the next thing I said, let's break our patients up into quartiles, our first 9, second 9, third 9, and fourth 9, but it actually happened to be 10 because there were 37. And here are our first 9 patients, where we didn't see very good results. And then the second, third, and the last 9, or the last 10 patients, we got better with time. So there is a learning curve with doing this process. We had been out to Rome, learned a bit through there, but they didn't treat chemotherapy neuropathy. We learned about low back pain and other things, but they didn't have a big oncologic population at that time. And what we learned mostly when you do these treatments, you go oftentimes on either side of the pain, ideally catching the same nerve in a couple different areas, but sometimes for back pain it's different nerves there, but on either side. But it's hard to get farther distant than the end of the fingers where the chemotherapy neuropathy is, or end of the toes. So what you do is you catch the nerves earlier, the same nerves that are causing the thing, and we catch them earlier to send that message to the brain. So then we have, this is the numerical information that we have on the 25 patients with lower extremities, and this is day 1 on through day 10. This is just the before treatment days. And in our data, when I showed day 10 of therapy, that was the before treatment information. Some of the studies by others have used the after day 10, after day treatment. And with each treatment, I think it's better, but I think it's better to use the before, my own bias there. So then, these are the first 7 patients that start off with pain scores of between 4 and 9, and they all had 100% improvement. And you can see the time frame for this, and this patient then dropped down. This patient we stopped treating because there was no pain, and as Giuseppe says, if there's no pain, you can't treat for these things. These are the middle of the pack, which is about the 50% reduction. And then there were some patients who didn't do so well. And one patient, actually, the pain got a bit worse. It went from 3 to 5, and then they ended up stopping there. When you see the 4th day with the X mark, that's when they stopped, and those were the same values carried forward, last values carried forward. These are the upper extremity patients now. And there were a few that had nice responses, scores of 8 and 9 dropping down to 1. There are some patients who had less ideal responses that you can see at the bottom there. And so the average response is about a 53% reduction in pain, like we talked about earlier. Now, we also looked at low back pain. Why is a medical oncologist doing this for low back pain? We saw it in Italy, and nobody else was doing this. We decided, let's look there. It actually looks, we looked at the first 29 patients we treated that had low back pain. That first study is published. This one is not yet published. It's been submitted. But the results for back pain, they drop more on the first day. It's a bit easier for low back pain. And this is not just early low back. These are patients who have low back pain, which is a chronic problem for months, for years generally for these patients. And sometimes the longer it is, the harder it is when people think, no way you're going to help this person. It actually does help quite a bit. And so these are the actual data, and the 9th and 10th day they had no pain afterwards. There is a dropout of some patients that you can see here. To help correct for that, if we use last value carried forward here in the same patients, so you're not biasing as much, there still is the drop that you can see right here. And then this is the information in patients that we asked up front, how bad is your back pain over the last week at baseline? And then we asked that weekly thereafterwards in the 10 follow-up weeks, and it drops down, and the benefit seems to stay around for those particular patients. Now, when our back pain data, we look to see with the patients who had this back pain, how much of it seemed to be neuropathic back pain versus mechanical, and it didn't seem to make a difference in terms of our benefit. There wasn't the neuropathic pain doing a lot better than the patient who had mechanical back pain. So looking at what other people have done, and I'm doing this kind of in a chronological stage after a couple of preliminary things to show which trials are out there. There are 15 trials and reports that I can describe here. 12 are published manuscripts, 2 are published abstracts, and 1 is our back pain study, which has not been published yet. 4 of the studies or 4 of the experiences are clinical practice experience, so they go back and looked at their patients that they had asked them, but they weren't really prospectively following them. 8 are prospective trials. 1 is a randomized controlled trial, open label, not placebo, and 2 are randomized placebo-controlled trials. The first trial, 2003, Giuseppe Marineo, and he's the inventor and that sort of thing, and so you just say this might be biased, and he's got something to gain and all that sort of stuff. Patients with advanced abdominal pain from abdominal sort of cancers. He noted that pain was quickly and markedly reduced. 9 of the 11 patients stopped their pain medications within the first 5 applications. No side effects, he noted. Pain reductions continued until death. There were some patients who had recurrent pain and months later were successfully retreated. And these are the data that he demonstrated in his hands here, with a pain score of about 8.5 or out of 10 or 85 out of 100, and dropped down the first day here and dropped down quite nicely here. It's almost, this is unbelievable. We don't quite think this and that sort of thing, but that's what he first published there. Second trial, 226 patients with neuropathic pain. He's a second author in this particular trial. Prospective trial. The details are a bit sketchy as to whether it was IRB approved or not. It was done in Italy, and it wasn't quite clear, or they just didn't say it in there, but noted that they had failed back surgery or brachial plexus neuropathy or other things. 80% had greater than a 50% reduction in the pain. 10% had responded with pain relief between 25 and 49%, and 10% did not have any response. And again, noted that there were no toxicities. Third trial, this is the first trial that was done without Giuseppe. This is Tom Smith, the trial that I talked about before that got me interested in this, looking at, when he heard about it, he said, let's try it for chemotherapy neuropathy. It's a big problem we see in practice. And so this is what he published, that it started off with a score of about 6 out of 10 and dropped down to about 3 out of 10, 2 or 3 out of 10. Now this was the last scores after the first day, which was before treatment. The other scores were at the after treatment for those days, which you might say is cheating a little bit, but anyway, that's what he has shown there. Next trial out there is 10 patients. This is written by Dr. Abdi, who's a anesthesiology pain physician, failed back pain surgery with a 28% mean pain reduction, which doesn't sound all that much, and maybe that's placebo effect. In talking to him, he said these are patients that everything else had failed. These were desperate sort of things. He saw some wonderful sorts of responses. Interesting, Giuseppe Marineo, after this was written, kind of letter to the editor back, or letter to the editor or something saying, hey, they didn't really treat it correctly, et cetera, et cetera. It wasn't done the way I would have done it. But that's kind of where that is. So the next trial here, again, Marineo is associated with this trial, and again, you have to say that could potentially be a weakness, especially he's the only person that's saying these sort of things. 52 patients with chronic neuropathic pain, randomized to Scrambler versus standard pharmacology guidelines, where he had somebody call and adjust their medications, call them once a week or something like that. They were post-surgical, post-herpetic, and spinal cord stenosis. The mean scores were 8.1 despite the medical therapy that they had had before that time. And what he noted in the control group, again, 8.1 versus At 10 days in the control group, it dropped down to 5.8, which was a 28% reduction, which is not too far off from trying to maximize medical therapy and calling the patients that thing. Similar scores at 2 months and 3 months. But with Scrambler, it dropped down to less than 1 with a 91% reduction, 1.4 and 2.0. He noted that the pain drug consumption decreased by 72% in the patients getting Scrambler, not necessarily the other ones because they were managing their pain medications. And allodynia, which is soft sheet or something like that, which really can hurt your hands when normally, hurt your feet or whatever normally doesn't, reduced from 77% to 15% at 3 months. And these are the curves that he demonstrated with this. And this was at the beginning. This was after he finished with Scrambler therapy, and then a month later and 2 months later. And it almost says, golly, this sounds bizarre. This is not, and it was open labeled and all that sort of thing in there. These are the different subgroups that he had: post-surgical, post-herpetic, and spinal cord stenosis. These are the patients who got Scrambler. These are the control patients, but you could see that they didn't seem to be much of a difference between which category they were in. Sixth trial is another group of Italian authors, but not Giuseppe. He was not part of this. And in fact, Giuseppe wrote afterwards a letter to the editor and said, they didn't really treat it correctly. They should have done it this sort of thing. And Giuseppe is, as I said, an interesting person, but sometimes may not be able to describe things as well. I think it might be too bright in ways. He can't put it down in a simplistic sort of way of how you actually put this into practice for people who don't have the experience he does. But 73 patients, 50% had cancer, prospectively treated on a clinical trial. Pain scores reduced 6.2 out of 10 before treatment, 1.6, 2.9, this is end of treatment, and 2.9 a month later. Some with cancer versus non-cancer. And they asked the question, would you repeat this treatment? And 97%, or 71 out of 73 patients said yes, they would repeat this cancer. On our trials, we've actually asked the question, would you recommend this for somebody else? I actually have not analyzed those data. I need to go back and do it, but I think the answer is going to be 90 to 95% from what I recall from talking with the patients. So the seventh trial, a series of cases of 39 patients with cancer pain syndromes, 33 of whom had chemotherapy-induced peripheral neuropathy. This is from the same group at Virginia Commonwealth University that Tom Smith was at, where they did that first trial, 16 patients with chemotherapy neuropathy. It's an IRB-approved trial. It's associated with relief of pain and sensory motor neuropathies, decreased brief pain inventory, interference scales, how much is pain interfering with your enjoyment of life and sleeping and all those sorts of things. There's 7 different interference they have, I think. And the benefit lasted out to 90 days, so 3 months after treatment was done. The 8th trial, again, is Tom Smith there and Marinero from here. 10 patients with post-herpetic neuralgia, and they noted a 95% reduction in the pain a month after a 10-day treatment was initiated. Some of these patients, it's not clear how many, were on one of the previous Marinero trials, but they just put them together with some patients that Tom had treated when he was at Virginia Commonwealth University. So the 9th report is actually not a clinical trial. It's some Korean authors who noted 3 patients in a case report sort of thing, but they were very impressed that these 3 patients who had intractable pain related to bone metastasis. And the next one was another one with 3 other Korean authors, also 3 patients, this time post-herpetic neuralgia. This time, again, they were impressed. They told you the case story of each of these patients that seemed to do quite well. Now, the 11th trial was a double-blind, placebo-controlled, randomized trial. It was in 14 patients with chemotherapy-induced peripheral neuropathy. The group here who did this trial had little experience. They were from Wisconsin, Toby Campbell. There was no difference between arms, but they had very little experience in doing this, especially for chemotherapy neuropathy. They hadn't done any pilot trials before and all. The sham procedure looked viable, that the people who didn't know whether they're getting sham or the real thing. They presented this as an ASCO abstract. There's not been any manuscript. I don't expect there's going to be, just because there's small numbers of patients and the inexperience, I think. So the 12th report is the Mayo CIPN manuscript that I showed you earlier on. The 13th report was a large clinical practice experience with 173 patients. This is from the Rhode Island practice. Steve D'Amato and Spiradio is one of his colleagues there. With CRIPS, chronic regional pain syndrome, neuralgias, back pain, and other things. Mean pain score was 7.24 prior to treatment, 3 immediately before the final treatment, and 1 just after the final treatment. And he noted that benefits seemed to last for 3 to 6 months in patients. 14th trial, retrospective clinical practice experience. So they looked back in the practices, patients they had there. This was 147 patients, pain from a variety of conditions, from the very first patient they treated on through later there, knowing that the investigators had different experiences during this time in terms of how well they were able to treat the patient. One was a Korean institution, and a couple were United States military institutions. A number of the military institutions, there are at least 3 of them that have had who have been using Scrambler therapy. And 38% of the patients had a 50% or greater pain reduction that lasted greater than a month. And in this trial, they actually had information suggesting that neuropathic pain did better than the other ones in terms of treating here. And then the 15th trial is a double-blind, randomized controlled trial published earlier this year in January. 30 patients with low back pain. This was at Virginia Commonwealth University. There were significant decreases in the worst brief pain inventory pain and with the interference scores. They also, with pain sensitivity, where over the area where there's pain, they put a little pressure of a needle there, and how much pressure did they have to put before the patient had pain, and it improved in the patients that got the Scrambler therapy versus not. And the other thing they had with a heat probe, they put how much heat was it before the patient got pain, and there was improved scores in the patients who got Scrambler versus not. And they looked at mRNA expression of 17 pain genes, and there were positive sorts of reports in those genes. I don't understand that quite that well and what it means, but again, this is a randomized placebo-controlled. Giuseppe made some comments about it. It wasn't done exactly the way I would have done it, but the fact that they actually saw the results here in this double-blind, and the patients were most of the patients, somewhere around 75% of the patients in both groups, thought that they were actually getting the real Scrambler therapy. What they did for the control, the sham, this was low back pain, so they put the leads about a dermatome above where they should be, and they didn't turn all the juice up as much as you could turn the juice up, but they did something, so they felt something, but didn't turn it up from there. So those are the studies that are out there. It's quite a bit, I think, especially when you see different authors who are seeing the same thing that Marineo first reported. So how does Scrambler therapy work? See if I can work this thing to make it work here. So this is something we came up with some time ago. If you have chronic pain, acute pain initially, and then it turns into chronic pain, this red thing going to the brain, and that you put on the Scrambler therapy leads, it sends a different set of messages up there to thing, and it gets the brain to feel again that this is no pain. Now, classically, when you treat patients, nothing works for everybody all of the time, and we all know that thing. But when you treat a patient for this, and you put the leads on, and it's something that works, and again, most of the patients it does work for here. You put it on, and it feels some buzzing sort of thing. It's kind of something like TENS. Now, Giuseppe will say it's not TENS, it's not TENS. That works to the gateway theory. If you've got touch sensation going in, then the pain can't go in there. And he has a totally different thought process on this. But when you put it on there, the pain goes away in about a minute or so. And Giuseppe used to say, well, ask him if the pain goes away. And I tried doing that for a while, but every time I asked them, they say, I can't tell. I have all this buzzing thing, and I can't tell. So rather, I rephrase it, and I say, has this buzzing sensation that you have, has that replaced the pain that you had? And if they say yes, then you got it, okay? If they say no, I feel the buzzing, but I still feel the pain, then you might not have it in the right area. You may have to change where to put the leads. You don't put it on exactly the same place. You can move it out or above it, so you can change things. And then if you get a successful treatment, while they're on the treatment for 30 minutes, they're comfortable there, and you stop the treatment, and then after the buzzing goes away, their pain is still gone. And then you send them on their way, and then the next day they come in and say, it was good, felt good for 30 minutes. an hour and a half, 2 hours, 15 minutes, a period of time, and then it came back. And they're a little bit discouraged by that process. But then that's actually a good sign. If it went away and stayed away for a time, that's good. You did something there. So you treat them the next day, and they come back and said it was gone for 3 or 4 hours. And the next day it's 4 or 5 hours. The next day it's 7 or 8 hours. And the next day it lasts through the night. So it's it's that training process that goes on is the best way I can explain it. So I said before, there's no proof that this works. And why do I say that there's no proof that this works? All of the trials have weaknesses. Even the last trial is a total of 30 patients, 15 per group. Giuseppe would argue it wasn't given the best way of giving the treatment because they said that they put on 2 leads, right? Get 2 leads for each line, and they put it here and one right below, and then they turned it on for that. He would argue, you put on 1 lead, you turn on, see if that's the right area. If that's not, then you switch it around, you change things around, and then you put on another lead if it doesn't take care of all of the pain process. But it's a relatively small trial, but the fact that it actually provided benefit is pretty good, but it's, again, that's the best of them, and it's still a pretty small trial. No large placebo-controlled trials. Ideally, with most of the stuff, when we have chemotherapy drugs, we want 2 large placebo-controlled trials to demonstrate it. Potential conflicts of interest. Some of the reports involve the inventor, but the fact that other people have looked at it is something. And there are multiple claims of other therapies where people have said this works and this works and that works, and then eventually you find out it really doesn't work. So why am I quite convinced that it does work? There are 2 positive randomized controlled trials. Multiple positive reports of greater than 800 patients from multiple investigators. All reports save 1 small abstract were considered to be positive by the authors. The claims of the inventor independently confirmed by others. And I've seen far too many anecdotes of patients that when nothing else has seemed to work, and it works. And they're in tears of joy for how and that's relatively right away in the fact that they can get this sort of thing. And too many patient stories of that that I've seen. Am I conflicted? Well, potentially I could. As I said, they provided machines and Mayo contract for some money. Gives me an opportunity to write and to consult. I've got to know others, including Giuseppe and all those sort of things. Get to come out to Portland, my hometown. So all those things could be things where you could say I'm conflicted. But on the other hand, why not? I actually haven't received the money. It's Mayo, and it actually hasn't received the money for there. Opportunity to write. I have plenty of other things to do. I have hundreds of publications. I don't need to do this. I need to more retire than go out to this sort of thing. But I got plenty of other things that I can do. And I've gotten to know others that know me would argue that will tell you I'm not shy about publishing negative results, and I'm not shy about arguing about people if they say something works, and I say, wait a second, I don't quite believe that, so I'm not afraid of doing that. So conclusions. No proof that Scrambler therapy works, that it provides remarkable benefit, but I'm convinced that it actually does do so. And I do have there is a patient video out there that somebody came, Reuters news agency came and came and talked to one of my patients who had bad chemotherapy neuropathy for a long period of time. Her pain was 12 out of 10, as she says on the video, and she's had a remarkable result that actually has lasted for over a year, and she's very, very happy with it. But if you want to see that, to see what the patients actually think, as opposed to myself, you can put Mayo Clinic Scrambler therapy in. You'll find it for there. Thanks for your attention. I'm happy to answer questions if there are any, if this is the right time.